السلام عليكم. Our course will be 3 days. I have full details of this surgery and this. Okay, slide clear now to everyone. And voice also clear. That's 1% golden pen. Ahmed Rashid for arrangement for this course. We'll start first with now voice is good. Voice now is good. Now you can hear me. I think you have a problem with your device. Okay, wait, all to answer us. Voice is clear. Okay, or the other, I think you have a problem in your device. We need confirmation from another one. Please, anyone can hear us? Now voice is good, it's clear. Okay, anyone have a comment about voice, you can send to us. But I think you have a problem with your device. Mr. Hamid, check again, please. Okay. Now we have an introduction. Okay, function of female now voice is clear. Anyone answer us, please? Now, what about voice? Now voice is clear. So anyone here? No. Now voice is clear, okay? Okay. So first lecture will be about anatomy and imaging of breast disease. Second lecture will be about benign lesions of breast, how to diagnose, how to manage, and so the lecture will be about breast cancer, will be about risk factors, will be about diagnosis, investigation, how to manage, how to do follow up. First of all, the female breast has three functions. Okay. First function will be technical function. Technical function means normal function of the breast of production of milk for breastfeeding. Second, in our society, the breast also define femininity and is opposite of gynecomastia, which shows undesirable. Third will be aesthetic function, include symmetry of the breast. As we told in this lecture, we will concentrate on the anatomical details of breast, which are of interest for surgery. First, the female breast located on the chest wall between second and 6 or 7 ribs. As we can see here, we remove the skin here and the breast located on the anterior chest wall between second okay, and 6 or 7. First is lateral to the sternum. We can find here the sternum and medial to mid-axillary line. Then in the posterior, the breast associated with fascia of pectoralis major muscle. Now the slide is okay. Now slide is okay. Slide is okay now.
يا باشا مفتوحه بس على الليكتشر دي 1 دي 2 دي 3 لكن مش مفتوح السلايد نفسها.
نفتح السلايد نفسها.
وضح الصوت بس الله يكرمك دكتور جمال. لو بتستعمل مايك ايوه كده اشتغلت خلاص السلايد.
طيب كده شغاله؟
السلايد اشتغلت لكن الصوت مش واضح، ده بس ظبط الصوت الله يخليك.
كده الصوت واضح؟
كده كويس.
طيب تمام. As we said, the female breast located on the anterior chest wall between second and 6 or 7 ribs. Can go for this slide. Direct, as we see here, the second border of the second rib, and this is the 6 or 7 rib. Medial to the anterior axillary line, we can find anterior axillary line here, and sternum is here. So the breast will be lateral to the sternum, medial to mid-axillary line. Posteriorly, we can find fascia of pectoralis major, this pectoralis major muscle, letter A. Posterior, we can find the fascia of pectoralis major, and sorry, B is pectoralis major, A serratus anterior, okay, C external oblique, and the rectus abdominis muscle. So borders of the breast will be lateral sternum, medial mid-axillary line, above second below sixth rib, okay, and posterior we can find the fascia of pectoralis major, serratus anterior, external oblique, and rectus abdominis muscle. Then now we'll continue on shape of the breast. Shape of the breast classically described as a combination of cone and hemisphere. We know there's individual variation, but ideal classic shape would be cone and hemisphere. The volume of the breast can be determined by amount of fatty and glandular tissue. So there's, as we said, there's variation due to different amount of fatty and glandular tissue. This glandular tissue become less dominant until the second half of pregnancy and become fully developed during lactation. So this is why breast of lactating woman or lactating female become big and larger than non-lactating female, because of the glandular tissue become fully developed. Then this fatty and glandular tissue is suspended by fascial ligamentum system and the skin envelope. The quantity and the quality and relation of these four factors, all these factors determine the shape of the breast. Then we'll go and brief for embryology of the breast. The breast develop as early in the fourth week as down growth from second mammary ridge or mammary line of ectoderm. So breast develop from the first week or in the first week from the ectoderm. There is a supernumerary nipple or even gland proper may fall at lower level of this line. We have a line called milk line. Okay, the nipple or gland are formed in the lower level or at the lower level of this line. Lobule formation occurs in female only breast, and starts or does after puberty. Each lacteferous duct is connected to tree-like system of ducts and lobules, enclosed by connective tissue to form lobe of the gland. Then we'll go for gross anatomy of breast and axilla. So, what's breast? You can see here. Breast is modified sweet gland. So, breast at the end is a sweet gland or modified apocrine gland. It's formed of 15 to 20 lobules. As you can see here, the chest wall, so major muscle, okay, ligament the breast, the lobule, duct, and the fatty tissue. So the breast at the end is sweat gland. Okay, it's formed of 15 to 20 lobules. The lobules, as we can see here, then this fat account for smooth counter, and most of bulk of the breast is fat. Most bulk of the breast is fat. As these lobules is connected together or separated from each other, these lobules separated, as we can see here, the lobules 1, 2, 3, 4, 5, and okay, this lobule is separated by fibrous septa from the subcutaneous tissue. Here, as we can see, it's called cobal ligament or suspensory ligament. Okay, so the summary of this slide: first, the lobule separated by ligament, as we see this white color here. This ligament is called cobal ligament or suspensory ligament. Between the capsule and the fascia over pectoralis major muscle, here is the loose connective tissue of the retromammary space. So, chest wall, the ribs, pectoralis major muscle, here, fat, the lobules, separated by ligament, cobal ligament or suspensory ligament for the breast, and the retromammary space. We can find retromammary space here. So we thought these lobules are separated. Each lobule drained by its lacteferous duct. This is the lobule on duct here, a lobule on duct here, and all lobule has its lacteferous duct into the nipple. We can see here multiple ducts surrounded by pigmented area. There's pigmented area here called area. This area is lubricated by gland. This gland is very, very important. What is the name of this gland? This gland is called Montgomery gland. Montgomery gland. What is the clinical importance of this gland? Sometimes patients complain of painful swelling, and after examination and imaging, as you would see in the next slide, or we found sebaceous cyst and they become infected. So, what is the source of the sebaceous cyst or origin of sebaceous cyst? This gland is the Montgomery gland. We'll speak in Arabic. أي مريض بيشتكي من swelling, pain, whatever the complaint. اوكي، لازم احنا بنوصف الكومبلين نحدد المكان. كده breast divide into 4 parts. There's two lines here, imaginary line 12 to 6, 9 to 3. So we have 4. First one, superior medial. Second one, superior lateral. Inferior medial, inferior lateral. This is not a common name. Common name, upper medial, upper lateral quadrant, lower medial, lower lateral quadrant. This is the common names. تقرير الأشعة أو في الهيستوري أو في الدوكيومنتيشن patient presented breast mass, breast swelling, breast lump, whatever the name. documentation لازم احنا بنوصف السويلنج ونحدد السايت. في سلايد بعد كده how to assess swelling، لكن بنوصف السايت. For example, patient came with right breast swelling. We should mention the site here: upper quadrant, upper medial, upper lateral, not first mass, first four quadrant. And you can consider breast as a clock, and we can describe the swelling, for example, at 2 o'clock, 7 o'clock, 10 o'clock, like this, upper medial, superior medial, or upper medial quadrant, about 1 o'clock. This is the description of swelling. The summary of blood supply of breast. As we said, breast is a modified sweet gland, rich blood supply. Mastectomy, bloody operation because of breast rich blood supply. Blood supply of the breast from two main arteries, the subclavian and axillary. subclavian في branch من subclavian اللي هو internal thoracic او mammary زي ما احنا شايفين هنا كده. تمام. هنا supply about 60% of blood supply of the breast. the subclavian branch اسمه internal thoracic or mammary artery. supply most breast 60%. هنا زي ما احنا شايفين هنا الاكسلري، في هنا اللاترال thoracic زي ما احنا شايفين كده supply about 30%. باقي البلاد supply of the breast في branches من الاكسلري زي superior thoracic, acromion superior thoracic, okay, acromion thoracic and thoracic and intercostal artery. Brief blood supply of the breast: internal thoracic 60% and lateral thoracic about 30%. Here the cadaver, okay. After remove the skin, the fat of the breast, letter A from lateral thoracic, as we said, branch from the axillary, supply only 30%. B and C here we can see second and third internal mammary vessel of perforator, and the fourth intercostal vessel perforator. Then about venous drainage of the breast. Main venous drainage of the breast runs via subcutaneous veins, as we can see here, and this subcutaneous vein of medical or surgical importance we'll see later. So main venous drainage will be via subcutaneous vein that flows to the sternum here, subcutaneous vein here, okay. So this is the main venous drainage, and vein run concomitant arteries, okay, but branch in the periphery. يعني الفين بيكون لها branch في periphery. Superior and medial they drain into internal mammary vein. Venous drainage of the breast، كل الفين بتتجمع في الآخر and drain internal mammary vein. Internal mammary vein has surgical importance. What's the surgical importance of internal mammary vein? As we said, these veins are superficial. So, due to the superficial cause of internal mammary vein, the vein can give us information about the cause of internal mammary artery. And we will see later the importance of internal mammary artery. So the vein, superficial vein, are of surgical importance. Then we'll go for lymphatic drainage of the breast. Lymphatic drainage of the breast very important. اولا احنا لازم نعرف lymphatic drainage of the breast. اولا during examination of the breast, lymph node examination, the part of breast examination. So lymphatic drainage of the breast originates from breast lobules and flows through intramammary nodes and the channels into subileal plexus. So from lobules to nodes to plexus. Plexus is called stapes plexus. Okay. There are three main routes for lymphatic drainage of the breast. This route is parallel to venous tributaries. We have difference between lymphatic drainage of the breast. Left is different from right. Left breast terminates in the thoracic duct. I speak about lymphatic drainage. Left breast terminates thoracic duct and left subclavian, and the right in the right subclavian. What are these three pathways? Three pathways will be axillary pathway or lateral pathway. This is the dominant pathway. Receive more than 75% of lymph nodes from the breast. What this dominant pathway drain? This dominant pathway drains the lateral quadrant of breast, may be direct or indirect via plexus, space plexus we said, to the axillary node. This axillary pathway runs around inferior border of pectoralis major muscle to reach the pectoral group of lymph node. Next slide or after two slides, we will have axillary lymph node anatomical region or anatomical corresponding of axillary lymph node. And we have two channels from superior breast to the apical group of lymph node, and sometimes this group of lymph node or apical group of lymph node interrupted by intraclavicular group of lymph node. So the axillary pathway, dominant pathway, 75% of lymph node, drain the lateral quadrant of the breast. This is the axillary lymph node. The axillary lymph node. About the axillary lymph node, we have three levels, surgical three levels. One, you can see here, one, this is the pectoral node, you can see here, pectoral node, and subscapular node here, so it's pectoral, subscapular, and humeral node. Then we have two central nodes here, as you can see, the central node here, some apical nodes here. Level number 3, apical axillary lymph node. So this axillary lymph node is distributed in 3 levels: the pectoral one, subscapular, humeral. We finish level 1. Finish 2, level 2, so there will be central and some apical. Level 3, mainly apical lymph node. Then second pathway will be internal mammary pathway. Internal mammary pathway will originate from the postmedial and the lateral quadrant of the breast and pass through the intercostal space and the pectoralis major into internal mammary lymph node and parasternal lymph node. This connection between this node may lead to may cross the median plane and hence to the contralateral breast. Breast is rich in blood supply and lymph node. The last pathway is the retromammary pathway. Comes from the deeper portion of the breast. So the first two pathway will cover the breast superficial. Now we come for the deep part of the breast, is drained by retromammary pathway and then into subclavicular plexus. Other pathway, but these are the main three pathway. Other pathway occur when usual channel are blocked. When there's a block in the channel, there's other pathway. Lymph may pass into the other breast or contralateral breast, cervical lymph nodes, peritoneal cavity, and liver through the diaphragm or through the rectus sheath. Breast have somatic and sympathetic nerve supply. Nerve supply will be from T4 to T6. It's anterior and lateral branches sensor to the skin of the breast, so sensation will come through T4 to T6. And we have sympathetic fibers to the blood vessels and smooth muscle fibers in the nipple and area. Now, we have surgical importance here. Patient did mastectomy, and after mastectomy, patient come with winging of scapula or failure of abduction. What would we think? In mastectomy, in general, we have about 4 nerves we have to save. And during the dissection, after removal of the breast, these nerves are obvious. We saw these nerves. If the mastectomy, we have to dissect around this nerves, and we have to clear this nerves. First nerve will be long thoracic nerve. Here we can see the long thoracic nerve. This long thoracic nerve, serratus anterior, innervate serratus anterior muscle. What is the function of this muscle? Contraction, boxer's muscle, and scapular stabilization. So after mastectomy, patient came with winging of the scapula. I think this is long thoracic nerve injury during mastectomy. Then the second nerve will be thoracodorsal nerve. This nerve innervate latissimus dorsi, and injury of this nerve lead to failure of abduction and extension and internal rotation of the shoulder joint. Then we have intercostobrachial nerve, sensation to the upper inner arm here. We have medial and lateral pectoral nerve. As we can see here, the medial pectoral nerve, the lateral pectoral nerve. Medial pectoral nerve innervates the pectoralis major, pectoralis minor, and runs over the lateral border of pectoralis minor, the medial pectoral nerve. Lateral pectoral nerve innervates pectoralis major. So injury of this nerve will lead to atrophy of pectoralis major muscle. Then we'll speak first about the axilla. Then we'll go for breast examination. We have detailed anatomy because anatomy is most important in breast, and before examination, because we should know what we will examine. And after examination, what's the importance of every part of breast? I found a lymph node. I can describe a lymph node. Found a mass. I can describe a mass to get diagnosed. زي ما احنا شايفين هنا الاكزيلا. الاكزيلا ديت لها شيب، ده بيراميدال شيب. بيراميدال شيب زي ما احنا شايفين. ليها anterior wall. anterior wall. ليها posterior wall، وليها medial wall، وليها lateral wall. anterior wall احنا شايفين هنا. هنا البكتيريوس ميجور، البكتيريوس ماينور. البوستيريور وول تكون من سابسكابيولاريس، بكتيريوس ميجور، لاتسموس دوساي. الميديال وول ناحيه الثوركس، lateral thoracic wall. lateral wall structures of the arm. So axilla, four walls of the axilla. طيب احنا عرفنا الاكزيلا. طيب هي الاكزيلا هنا بيكون فيها ايه؟ The most important structures of the axilla: cords and the branches of the brachial plexus. Cords and the branches of the brachial plexus. axillary artery contributors او البرانشز بتاعته. وعندنا الاكزيلاري فين؟ في axillary lymph node, axillary fat, axillary lymphatic vessels. كل النيوروفاسكولار اللي هنا في حواليها شيث اسمها axillary sheath. Now we finish anatomy and embryology of the breast. We'll go for congenital anomalies of the breast. Breast congenital anomaly may be in the breast or on the nipple. What you can find in the nipple? We can accessory nipple. The long milk line look like pigmented mole. هنا زي ما احنا شايفين هنا accessory breast اللي هو axillary والاxillary breast. axillary breast او الاكسسوري breast ده بيكون كومن في الاكزيلا. هيكون تندل بري منسترال، ممكن يبقى تندل ماشي، وممكن يكون في نبل وفي اريولا اند بروديوس ميلك. الاكسسوري دوت ممكن يكون هو swelling, just swelling. ممكن يكون complete breast with nipple and areola and produce milk during lactation. The question here: how to differentiate from lipoma, successful breast or lipoma? It's difficult to differentiate. We can't differentiate. Difficult to differentiate. The next question: is this axillary breast can go malignant transformation? Yes or no? We need answer, please. We need answer. This axillary breast can go malignant transformation? Yes or no? Any answer? Question again. Can axillary breast go malignant transformation? No. Okay. احنا قلنا ان الاكزيلاري بريست دوت ممكن يكون فيه نبت في اريولا and produce milk breast, so has the same benign and malignant pathological potentially can go malignant or benign changes or lesions. زي ما احنا شايفين هنا اكزيلاري بريست. البريست دوت احنا بنعمل له اكسجين. ادي هنا بنعمل elliptical incision، نعمل complete removal. وهنا الصورة الأخيرة appearance after local excision of involved tissue. We have another congenital anomaly is absent breast breast accessible. Accessible breast is completely different. Absent breast. Maybe one, maybe two, and the nipple will be preserved. Nipple will be preserved. Then this nipple can be retracted. Can be retracted. Now we'll go for the next will be breast examination. We'll take rest for 5 minutes and we'll go for breast examination. Thank you. السلام عليكم. هنكمل second part of our lecture today. We'll go for breast examination and screening tools. Breast examination, we have self-examination and clinical examination. About self examination, Self-examination is a technique which allows the individual, whatever male or female, examine breast tissue for any physical or visual changes. Breast mass is a common cause for women for which seeking treatment and the most common presentation of breast cancer. Examining the breast should be with lymph node, when managing the breast mass. Clinical or self-breast examination to self-breast examinations controls benefit. Sensitivity should be done about 50%, and this examination should be done as a part of physical exam for screening, but not only the screening tool. So the self-examination should done, but not the only screening tool. Now we'll go for self-breast examination. After finish, we'll go for clinical examination. First, self-breast examination. When we will do self-breast examination, at the better at the end of period, okay. But in pregnant, no period in pregnancy, so we have a specific day each month for examination. The hand must be dry and warm, so this examination shouldn't be performed in the shower or with lotion on your skin or the finger. During examination, if the patient or the person found a mass, about 80% of this breast mass or breast lump, not a cancer. So don't panic. I will seek for medical advice for more evaluation. Now we'll go how to do breast self examination. First, stand in front of a mirror and look close to your breast in the following position. We have three positions for inspect the breast. Okay. First, arm at your side, as we can see here, arm at your side, the mirror. Okay, and just look. The second position, arm will be raised above your head and bending forward. The third position, hands placed on hips and leaning forward. So what we will look for, first shape. We'll look for the shape. We'll compare right to left. Normally, one breast may be larger than the other. Normally, may be larger than the other, but sudden change in size shouldn't occur. So we'll look for the shape and compare right and left. If we found one, for example, right bigger than left, it's normal. Okay, but the second month, next month, the same size, okay. But when we have a change in size, no, we should have a seek for advice. And you will check the skin or observe the skin, check for rashes, redness, puckering, dimpling, or wood orange appearance of the breast. So any change of usual skin should go for advice for more evaluation. Also, when observe nipples, check for any physical changes as recent inversion, redness, swelling, or discharge. We have also we said in venous drainage of the breast that veins subcutaneous and superficial. So we look increased size of veins or number of veins compared to the other breast. Now we finish observation. We'll go for palpation or self examination. Now, as we can see here, we'll go for examination of the outer half of the right breast. The patient or the person who will lie down and on the left side to examine the right breast. Lying down, okay? We can use a pillow behind shoulder and back. Will be more easy and more comfortable. Go down to the left side now to examine the right breast. And the hand will place our hand or the patient hand palm up on your forehead as we see here. How I do this? To start examination to have a space to examine. In this position, the breast will be lie flat on your stool as possible. It may be either, as we said, we have a pillow. So this is the position of examination of the right breast. When examining the left breast would be the opposite. Then we'll use the flat bed, as we can see here, of 3 middle finger here. We'll move these pads in little circles about the size of a dim. We'll move this pad here, little circles. Each little circle will assist will change the amount of pressure, so you can feel all levels of your breast tissue. Use pad, apply minor pressure, moderate, then deep pressure. Will change the pressure to assess all tissue. Okay, as we said, once light, once medium, once deep before you move the next area. So in this step, we'll examine the breast, we'll use a pad, apply pressure, different pressure to assess all breast tissue. Then by hand, again, we'll start circle in your arm pit and move down just to the line. Then, as you can see here, we slide the finger over and just the width of one finger and move up again. We move up and down to feel the breast tissue. But the kill here, don't lift the finger. We'll move the finger up, down, then move finger side a little bit, move up, down. Don't lift your finger from the breast to make sure you feel the entire area. Because if you lift your finger, you may place your finger in another area and you will miss areas not examined. We'll continue to reach the nipple to examine the whole breast tissue. In previous step, we examined the lateral part of the breast or outer. Now we'll examine the inner half of the right breast, as we can see here. From the previous, we reach the nipple. Then, when you reach the nipple, remove the pillow and go into your back. Patient or the person will be spine, and the hand will be removed from the forehead, and place the right arm or the arm in right angle, as we see here, the right angle, and the position of the arm. Carefully check the nipple and the same circular pressure as before, as we said, light, medium, and deep. But don't squeeze, nipple, not squeeze. Nipple, not squeeze. Then we'll continue up and down till examine the entire breast till you reach the mid line here. First we reach the nipple, then we change position and start to move to till reach the mid line. Then non-palpating hand, the hand, non-palpating hand, down at your side, make row of circles above and below your collarbone. From shoulder to the mid line, as we can see here, the hand move up, down, change pressure, don't lift your hand, and don't forget both breasts must be examined, not only one. Self-examination, as we said, done once monthly after period of pregnant or irregular cycle. We have to do breast examination specific day per month. Then we'll go for clinical examination of the breast. What is the importance of clinical examination? The goal of clinical examination to determine if the breast normal or abnormal. If any abnormality may indicate surgical consultation, re-examination, different time of menstrual cycle, and investigation like mammogram or ultrasound. Examination would include inspection and palpation. But first, we have to know the steps of clinical examination. Patient must undress down to the waist, examining table with access from both sides. Okay, and we should have a light with an assistant to focus the light from one area to another area as examination being conducted. As we said here, examination or clinical examination of the breast include inspection, palpation, and during examination we will change the position of the patient. So we said the table must be free on both sides because position will be changed. And we have to palpate all the breast. We should examine two breasts. Even patient will come complain, for example, doctor, I noticed swelling in my right breast. So we'll examine right and left, not only right to be examined. First of all, you have to wash your hand. You have to wash your hand. You have to introduce yourself. Hello, I am Dr. Jamal. Can you then your confirmed patient name and age? Can you tell me your name, your age? Called WHO checklist. Okay. Then you have to inform the patient what you will do. لازم المريض مفيش اي اجراء بيتعمل بدون موافقه المريض. لازم اي مريض يعرف بالظبط انت هتعمل ايه وايه الامبورتنس والفايده اللي انت هتعمله ده. قالوا النهارده هنفحص الثدي الايمن دوت، احنا هنبص بعينينا وهنشوف، وبعد كده هيكون في بالبيشن للبريست دوت، احنا هنشوف لو في اي ماسز، في اي سويلنج، في اي lymph node. Okay, then you will take verbal consent from the patient. Is it okay? تمام. في اي سؤال نبدا الفحص. طيب في اي الم؟ السؤال المعتاد، في اي الم؟ في الم. كنت ارد على المريض ان تديله مسكن. احيانا المريض لو في بريست ابسس مثلا، مريض بريست ابسس سيفير بين سأل المريض في الم؟ في الم. انت ممكن البيشنت ياخد مسكن قبل ما تبدا الاكزامينيشن. زي ما قلنا الاكزامينيشن عباره عن انسبكشن، then palpation، Okay, and lymph node. Don't forget lymph node. You should have assistant. You should have assistant. No patient, even male, even male, no patient can be examined without assistant. Even male patient, even male patient, not examined without assistant. Whatever the situation, whatever the situation, we have a problem before previous hospital, doctor examine patient without assistant, patient complain against him. And he, I think he's, yes, I think he's male, yes, and complain against him. And they will ask the patient, do you have any question? Do you understand what I will do? Yes, I understand. No, I didn't have any question. Okay, I will go for examination. Okay, just verbal consent. As we said, patient will be undressed till the waist. If patient had concern about swelling, lump, ask the patient to locate or to point the lump before examination. What we can find in examination? We can find swelling, hard, mobile. We can find here big swelling, node swelling, maybe mobile, maybe hard, maybe fixed. Okay. Uh, we can find skin changes, can find level charge. It's a common presentation or common found in examination. Now we'll go for first examination inspection. About inspection, I have visual inspection. The patient seated, not supine, arm overhead, and hand on hips, pressing tightly. Assess. What will assess? Symmetry in shape, skin changes, especially erythema or redness, retraction of nipple, dimpling, changes, if any, secretion, summary, and we will examine lymph nodes, cervical lymph nodes, supraclavicular lymph node, and axillary lymph node. Examination of lymph node most very very important in breast examination. Then patient would be lying down. As you said, hand will be overhead. I'll do vertical strips and circles, wedges to examine the entire breast. Then we'll use pads of fingers and palpate superficial, intermediate, as we said, 3 level of palpation. We'll go in some details about examination. Patient must be centralized. How we know patient centralized? By level of shoulders. And we will examine for any masses, scars, or asymmetry. Arms by side, position of the patient with the hand on their thighs. Will inspect for scars and site scars. Okay. And the scars is large or small scars. As we said, asymmetry. Normal breast or healthy breast are often mildly asymmetrical. Mildly asymmetrical, not 100% symmetrical. There's mild asymmetry, and we said maybe one breast is larger than the other. Well, respect for mass, size of mass, position, and skin oval. And we have to respect for skin changes, especially spot range because It's a sign, one sign of malignancy. Dimpling or buckling indicate malignant mass, erythema, infection, or malignancy. We can diagnose or suspect breast cancer from the skin before you examine. You can suspect patient malignant or not. Not sure, but you can suspect. Okay. Then we'll inspect the nipple for discharge, and we'll go on detail for nipple discharge, nipple retraction. Nipple retraction, as we said, may be congenital or may be acquired, like fibrosis or malignancy or ductictasia, and we'll go on detail for ductictasia. Skin, as we said, or erythema, maybe eczema or Paget disease, malignant disease of the breast. Then hands on hips. We'll ask the patient to place hand on their hip and push inward. Okay. How is this? To tense because measure, and we'll repeat inspection for any masses. Okay, if you note a mass, observe to see if the mass move with the pectoralis muscle. Okay. If the mass move with the pectoralis muscle, this suggests invasive malignancy. So inspection is important because you can suspect the patient will have had malignancy, and then you will go for palpation and screening or radiology. Then the arm will be above head. You will ask the patient to place both hands behind the head, and also you will inspect for masses, asymmetry, and dimpling. You will ask the patient to lean forward, keep hand behind head, or catch a back of chair in front of head. Then you will repeat inspection of the breast tissue as above the other breast, and this position leaning forward will exacerbate skin dimpling, which means related to any underlying mass. Then we will go for palpation. Palpation of breast in palpation of abdomen. If patient, for example, had right iliac pain, although like C shape, will start away from pain. In breast, we'll examine the normal breast first. We'll examine the normal breast first. So we told we'll inform the patient what we will do. Maybe patient not understand why you examine the normal breast, and you will have a problem. So number one, we told we have to discuss with patient. I will examine you. For example, patient had right breast mass. To inform here, I will examine the first left breast to compare the other breast, so patient get understand it, and you will avoid problems. Then position of the patient. Patient must be on bed at 45 degrees. Ask the patient to place their hand on the side, being examined behind the head. Small pillow under the shoulder. We will use palmar aspect of the distal phalanx of index, middle, and ring fingers to compare breast tissue against chest wall. And again, you will feel if any masses. In examination, we must be systematic to examine the entire breast, maybe a radial method, maybe a spiral method, okay, or strip method, start from the axilla. During examination, you found a mass. Don't stop. Complete your examination. Don't stop. Complete your examination. If you put in your mind the examination, you will examine the breast within 5 minutes. Not more than 5 minutes. Less than 5 minutes. Okay, if you detect a mass, complete examination of the remaining breast before you examine the mass. Please don't forget the axilla. Axilla, the part of breast, must be examined during breast examination. Axillary tear, palpate the axillary tear of breast, and you just, or you should put in your mind the only part of breast that lies deep to the deep fascia, and majority of breast cancer, common site of breast cancer will be upper outer quadrant. So it's essential to be examined because most of cancers will be upper outer quadrant of the breast. Then about palpation and the examination of the nipple. For example, the patient will tell you, doctor, I have nipple discharge. You will ask the patient, to squeeze the nipple to demonstrate the discharge. Then do pressure test to determine source of discharge. Discharge may be yellow, may be green discharge, mostly with infection, blood discharge, most suspicious of malignancy. Again and again, palpation should be in both places, not one. I know the patient complaint, right breast mass, but you have to examine the left. You have to examine both breasts because patient may complain of right breast mass and she had problem in left breast. Small mass in left breast can't be detected by self-examination, or the patient from the start didn't do breast examination. Now we'll go for breast lump, and as we said, breast lump common presentation for breast cancer. First, the position. So we told the breast for quadrant, upper, medial lateral, lower medial lateral. Okay. So you have to describe the position of the breast mass. Which quadrant of the breast is this mass located? For example, upper outer quadrant. If you want to be more meticulous, you'll use our, like this example, patient have upper quadrant mass about 8 o'clock. And this mass, how far from the nipple? Because the distance between mass and nipple of surgical importance during surgical management, as we will see later. First, position. Second, size and shape of the mass. This mass approximate about 2, 3, 4 centimeter. Okay, mass shape, as you see, the mass regular, elongated, and then consistency of the mass. When you palpate the mass, what is the consistency you feel during palpating the mass? Overlying the skin, most important and very important, because we told erythema may be or redness, may be erythema, may be malignancy. Then we'll go for mobility. Assess degree of mobility is mass move freely, fixed, move with or within the tissue. His mass is attached to overlying skin. Okay, his mass is enclosed with major, then fluctuants. Hold the mass by its side, fluctuation. Okay, you hold the mass by its side, then apply pressure with another finger to the center of the mass. It's called Paget test. So you will hold the mass, then you will apply pressure. Maybe fluid cyst. Okay, then you should feel the side bulging outward. Axilla. Axilla, as we said, axilla is a part of examination of breast. The position of patient during examination of the axilla. The patient sit on the edge of the bed facing you. Support the patient arm on the side, being examined with your full arm. If you examine the right axilla, use your right arm to support the patient. So you have the patient facing you, and you have to support. If you examine the right, your right arm will support the patient. If you examine the left, your left arm will support the patient. Then palpate the axilla with your free hand, and you should examine and cover all area. Axilla, as we said, medial wall or central. You will move your hand or palpate against chest wall. Lateral palpate against humerus bone. Anterior palpate against axillary fold. Posterior wall against posterior axillary fold. Apex of the axilla. Spy manually, hand in summit of the axilla, and the other in the infraclavicular fossa. And you should, if you have a lymph node, you have to suspect malignancy infection like this. Okay. Other lymph node should be examined as cervical and supraclavicular and parasternal lymph node. Okay, now we'll go for the screening tool for breast. We'll have rest about 5 minutes, then we'll go for the screening tools. Assalamu alaikum. we will complete the part of our lecture today will be screening tools. First, screening mammography. Screening mammography will depend on age. More than or 75 or more. No trials to do mammography are not done, but we can continue for patient who can tolerate surgical excision with life expectancy at least 10 years. From 50 and 74, we'll do screening mammography every 1 to 2 years, reduce the mortality by 20 to 30%. How mammography reduce mortality? Because we can detect any mass, so patient will not come complicated or come late, so mass can be detected. This means by reduced mortality. From 40 to 49, controversy. We'll discuss cost-benefit ratio with the patient, or what is the advantage and disadvantage with the patient, and if the patient agree or requested to do, we'll do every 2 years. Less than 40 is not recommended. So 40 to 74 every 1 to 2 years. Less than 40 not recommended. As we said, mammography detect 80% of cancer before lymph node spread, and this is what means by reduce mortality by 20 to 30. We have a rule of 20 in mammography. Mammography reduces risk of breast cancer by 80% and the mortality by 20%, and the mortality by 20 to 30%, and they can mess up breast cancer up to 20%. Overdiagnosis and overtreatment are high 20%. Okay, it's unclear if it causes more good than harm. Mammography, we have digitalized mammography, we have conventional mammography, and we have digitalized mammography. Okay, digitalized mammography is better in postmenopausal with dense breast only. Look, take care, or we need to put in mind dense breast has higher risk of cancer. We have 3D digital mammography. 3D digital mammography is called tomosynthesis, is new modality with higher detection rate, but disadvantage is higher radiation dose and cost. Always ask for magnified, and always will ask for magnified mammography. We can see here mammography. This is a 2D mammography. There's a mass here, and the 3D mammography. You can see the difference here between 2D and 3D mammography. Then we have this after mammography. We must have a report scored by blood breast imaging reporting data system. This system or this report will classify abnormality of mammography. The mammography report will be written by blood 1, 2, 3. What does this mean? We will know in this slide. 0. All right, 0. 0 is incomplete. Need further work up. 1. Negative. Need routine work up. Or 3. Benign. Followed by the mammography plus or minus ultrasound at 1 year. So the patient comes to you complaining, whatever the complaint, just pain, mass, cyst, and you decide to do mammography for the patient, and you have the report as pilot is 2. You tell the patient have a lesion from the liver, benign, have to do routine mammography. If all, and you can add ultrasound at 1 year. But if 0, incomplete. The most important here is 3. 3 is probably a malignancy. Okay, so we have low risk and high risk. Low risk and high risk will go for little slide. The high risk population and the low risk population. So if low risk will follow up with mammography in 6 months, high risk will do mammography, guided biopsy or biopsy. If biopsy result come back as benign or intermediate and malignant. So have 3 according to the risk, low risk or high risk. Low risk follow up, finish. High risk will do biopsy, and the biopsy histopathology will come benign, malignant, intermediate, or intermediate. Benign will follow up with mammography in 6 months. Malignancy will go for malignancy. Okay, lecture or the last lecture, or it is intermediate will do excision. Four. In 4 classification, 4, be suspicious. More than 4 the risk of cancer. Biopsy should be done. We said in 0 is complete. Okay. 3 most probably malignancy less than 2%. Okay, and will do as risk. But if 4, biopsy should be biopsy. But if 5, highly suggestive malignancy, more than 90% risk of biopsy cancer, more than 90% risk of cancer, biopsy should be obtained for both, and 6 proven malignant. Now we'll go features of malignancy in mammography. First, we should know the normal mammography or mammogram to detect the abnormality. As you can see here, the benign lymph node, this is adipose tissue, okay, and the duct and glandular tissue. As you can see here, the normal mammogram, and this is the pectoralis muscle. So, what is the signs of malignancy or features of malignancy in mammography? Here we have a mass. We have a mass. This is a mass here, as we see here. Mass. This mass may be speculated or satellite lesion. Would have a picture for this mass. Okay. Or we have calcification. We have calcification, as you can see here, is the calcification. About 75% of calcification are malignant. Not all calcification malignant. 75%. This calcification, as we can see here, small, irregular, okay, may be branching calcification and heterogeneous in size and shape. We said you can ask for magnifying. So magnifying gives you helps identify the calcification as it may be small and misdiagnosed. Okay, so maybe we have a mass like this. We told this mass circumscribed mass, the satellite lesion here, and we have calcification, small calcification, irregular calcification, and branching and heterogeneous in size and shape, and we can request also a magnifying. Here we can see asymmetrical density in the left breast. The left is the right, asymmetrical density. So all these signs of malignancy. The question here, in breast cancer, mammography 100% will be positive. Patient had breast cancer, okay, and she did mammography. Will be positive 100%? No. From 10 to 15 of cancer had no mammographic finding. Mammography may be normal, and the patient had breast cancer, about 10 to 15%. Okay. Then we will go this mammography, as we said, calcification, cluster of very tiny sand-like calcification, as we can see here, the calcification suggests most probably intraductal carcinoma. But as we said, 10 to 15% may be mammography negative or normal, and patient had breast cancer. Now also we have here calcification, as we can see here, small calcification here in mammography. Then we'll go for high risk population. High risk population, patient of first degree relative with BRCA1 mutation, start age of 25 baseline or 5 to 10 years prior to age onset of cancer in younger member. Okay, who had family history of breast cancer, considered high risk population. Patient with first degree relative with BRCA mutation, also high risk mutation. If history of premenopausal to first degree relative or ovarian cancer, first degree, okay. In positive family history, okay, of breast cancer or ovarian cancer, we will start screening 10 years younger than the relative age, but not before age of 25, as we told here, we'll start at age of 25, okay, not before. If patient had history of chest wall radiation, breast cancer, atypia, ductal carcinoma, or lobular carcinoma in situ, will do annual screening after diagnosis. Annual screening after diagnosis. So this is the high risk, positive family history, history of chest wall radiation, first degree relative with BRCA1 mutation. What is the risk of screening mammography? You use mammography as a screening tool for breast cancer. We have a risk of screening using mammography, maybe false positive 10%, about 10%. Okay, radiation very very low, average risk, maybe sometimes painful. So the risk of screening, as we said, false positive 10% and higher in younger patients up to 50%. Okay, so the younger patient will have false positive results than older patient. Radiation very low, only 2 to 3 milli. You would safe for average risk, okay, and may be painful, so patients feel discomfort. We'll go now for the next screening tool will be ultrasound. ultrasound for patients more than 40 years. More than 40 years. And ideal for pregnant patients below the age of 30 with dense breast. As we said, it's more than 40 years. Adding ultrasound to bilateral mammography might increase false positive finding with no reduction on mortality from breast cancer. As you can see here, the ultrasound of the breast is completely different from the mammography. As we see in mammography, what we can see in the ultrasound is normal ultrasound. This is the muscle. Here the muscle, the rib. Here the pre-mammary fat, mammary layer, this mammary layer. Gives normal ultrasound. So the ultrasound, as we can see here, the cobalt ligament, okay, superficial fascia, anterior leaf, superficial, all this superficial fascia, anterior and posterior, transmedial muscle, retroglandular fat, mammary zone, and this is the skin. Now we'll go for MRI as screening tool. The sensitivity of MRI is 98% to 98% sensitivity, but the problem is high cost. So the MRI is reserved or keep for patient with high risk of breast cancer will add to mammography. So mammography, then we can add MRI, but not routine done. In BRCA1 gene first degree relative was breast cancer that suppressed malignant axillary node with negative mammogram and in augmented or reconstructed breast. Here we have a question: the modality or screening tool of choice in augmented breast is MRI. MRI. Patient come, she did augmentation or the reconstruction of the breast, will go for MRI. Will not use for screening in average risk patient, as we said. Screening it will get augmented breast, but will not use for screening in average risk patient. Okay, with no survival benefit because it increase mastectomy rate up to 20 because of radiation. We finish radiology, then we'll go for biopsy of breast. We have many type of biopsy of breast. First, fine needle aspiration. As we can see here, we have a palpable mass here. Okay, we'll use a fine needle aspiration using needle average size from 20 to 22. It's a part of physical diagnosis, but the main problem of fine needle aspiration, it can't differentiate between invasive carcinoma and the carcinoma in situ because different management. Then we have TrueCut, the TrueCut or bone needle biopsy. As we can see, the needle is reduced to the mass, and you can take the biopsy. Okay, and the method of choice for tissue diagnosis. Take a tissue. So it's method of a choice. We have a guided core biopsy through image. Okay, the method of choice for tissue diagnosis for palpable and non-palpable mass. In TrueCut biopsy here, we should palpate the mass first. Then after palpation, we'll go for core biopsy. But image guided will be ideal for palpable and non-palpable mass. What the image you will use? You can use mammography stereotatic. We'll see next slide. Okay, ultrasound for MRI. How many biopsies we will take? We'll take 3 to 5 biopsy, sensitivity up to more than 90%. What's a stereotatic device? Okay, it would be under reconstructed mammography, but the problem not well tolerated as an ultrasound guided. Okay, and its choice for great benefit for non-palpable lesion. We can see here, this is the ultrasound guided biopsy. This is the probe of ultrasound here, and this is the needle for the biopsy. Can detect the mass here. We can see the mass here. Okay, and this is the needle, and we take the biopsy. Okay, this is the biopsy needle here. I can see. Then by ultrasound, we can see the needle penetrate the biopsy. Okay, then we'll do post biopsy mammogram, documenting markers placed within the mass. We'll do the marking here and do the mammography as medical legal and documentation. We thought this is a stereotactic computerized support, or this is the device. So, what is the indication? As we said, pilots 4 and 5, ultrasound guidance for mass and the mammography guidance for calcification, for biopsy should be performed for palpable mass in clinical examination. And 3, suspicious mass exam, patient anxiety or surgeon suspicion for malignancy. Do we have contraindication for stereotactic biopsy? Yes, we have contraindication in obese patient more than 130 kilograms. If patient non-cooperative, if lesion superficial, classification pilots less than 2 or less. Okay, lesion close to chest wall, relative contraindication, but absolute contraindication. Patient obese patient non-cooperative or superficial small lesion, and the classification 2 or less. Okay, cross chest wall is relative contraindication. You can do and you cannot do, no problem. Now we have a biopsy from the breast mass. Then we will have the report. What we would see in the report? Mass would be benign or malignant. If benign, we'll do follow-up. Malignant, we'll identify histological features and receptor status, or may be inconclusive. About 10% of biopsies will be inconclusive, so we'll repeat the cold biopsy. If still inconclusive, we'll go for surgical excision. What is the complication of biopsy? Pain at site of needle, bleeding, infection, vasovagal, maybe patient go vasovagal attack due to pain, or inconclusive result. Then, can pneumothorax? Yes, but it's extremely rare. Here we have breast cancer unit. We didn't see pneumothorax at all. At all. No pneumothorax at all. Okay. Maybe a spreading cancer cell along the biopsy tract is a possibility. Okay. Now we have image-guided needle localization and excisional biopsy. We can do in highly suspicious classification on mammography without palpable mass. Now patient come with non-palpable mass, and we did mammography, as we see here. We can find the classification, so we'll do image-guided needle localization and excisional biopsy. During surgery, we'll do excision of the lesion, then we'll send to X-ray to confirm complete removal of suspected lesion. We have about 2-3 slides to finish. Within 5 minutes, we'll finish, inshallah. Now we'll go for surgical biopsy, the excisional biopsy. Okay, this is the definitive method of tissue diagnosis. Follow needle localization of both biopsy. Will do surgical biopsy. Follow needle localization. We have important consideration in surgical biopsy. Must be taken with safety margin. Okay. Then orient the biopsy incision in way so it can be incorporated into mastectomy incision. When we do biopsy, okay, should orient the incision. The incision would be curvilinear over the tumor along Langer's line, okay, and radial incision should be used in medial aspect and lower half of the breast. If lesion superficial, we'll use elliptical incision at the point of wire entrance. So I was guided for excision, as we can see here. Okay, this is the mesh. This is the incision. The Langer's line along the Langer's line. Okay, we'll remove the mesh with safety margin. Indication of surgical biopsy. Atypical hyperplasia. We'll go later for atypical hyperplasia. Non-diagnostic specimen, we did mammography, we did core biopsy, image guided, but it's non-diagnostic, and stereotactic biopsy could be an option because it's more and more sensitive. Cellular fibroadenoma, okay, phalloid tumor and the papillary lesion, because phalloid may be benign or malignant. Radial skull will go for radial skull in details and phalloid tumor in details. Then genetic testing. When we do genetic testing for patients with breast mass, breast cancer, Ashkenazi Jewish, about 2%. Ashkenazi Jewish. These people who originate in Eastern Europe. There's personal history of breast cancer. Okay, diagnosed 50 or less years of age, or diagnosed 6 or less years with triple negative breast cancer. 2 breast cancer or more than 3 different cancers in the same patient. The patient had 2 breast cancer, right and left, for example, okay, or had 3 different, for example, cancer breast, cancer ovary, cancer colon. Will do genetic testing. If we have personal or family history of breast cancer, the 3 or more first or second degree of any cancer, then patient exclusive Ashkenazi with no history of cancer, but with first degree, patient had no history of cancer. Okay, but the first degree was breast cancer, ovarian or fallopian tube cancer at any age, bilateral breast cancer, male breast cancer or medullary cerebral carcinoma, pancreatic or metastatic prostate cancer, or 2 first degree relative with breast cancer at any age. So do genetic. Yale model, okay, depend on 7 factors: age, depend on age, race, menarche, first life birth, number of first degree relative with cancer, presence of atypia, and number of breast biopsy. Used initially to identify patients at high risk at high risk of having breast cancer to give them hormonal therapy, but now it's used to assess risk in general. Okay, it doesn't include genetic factors like a gene. Increased risk on Yale model is defined as 5-year projected risk of 1.7% or more. Then we'll do bone uh, scan. 25% of asymptomatic patients have positive bone scan in stage 3 of cancer, but in early cancer, no. Then we can do CT scan, it's called the static workup, and we'll go later for static workup in details. Then PET scan, okay. We hope this gives promising result. Now we finish our lecture today. Thank you all. Tomorrow, inshallah, at the same time, we'll have lecture about disease of the breast. After tomorrow, inshallah, we'll have the last lecture about breast cancer, about types of cancer, management of different types of cancer. Thank you all. Assalamu alaikum.